All right, so to start off the discussion, one of the problems, it's a fact that the length of stay at rehabilitation facilities is getting shorter and shorter. And the first question I'd like to pose to the panel is, what issues does that create in terms of discharge planning? Martha, do you want to start that off?
From a private practitioner's perspective, we usually see patients right at the very, very beginning when they're first injured at Sunnybrook. So the process of starting to plan for discharge happens absolutely immediately, with the most important issue being housing and transportation. So I think that the bigger issue really relates to Lyndhurst Hospital, and I'm going to let Heather talk about that.
Well, I'll say it's not a Lyndhurst Hospital issue, but I think it's a health system issue that I think we've all seen. Certainly rehab length of stay has drastically decreased, but also we're seeing people are coming to rehab much sooner. I think when I started at Lyndhurst, it was rare that anybody would come to rehab less than 2 weeks before, or less than 2 weeks after their injury, and certainly now that's quite common. So it's shifted everything, I think, to start sooner, which has really put pressure, I think, on individuals with spinal cord injury, their families, and the healthcare teams to really start making decisions much quicker, and sometimes not making decisions at a time when they feel ready to. So making decisions around equipment, around housing, at a time where emotions are very high. So I think it's really challenged us all to think differently. Certainly gone are the days when someone had months to decide what they wanted to do in terms of housing. I think it's also led a lot more people to move into temporary situations. So, I mean, I think that's the perspective I'm seeing. But what I think is important is that we really need to see more resources in the community. The pressure has been to shorten length of stay. But the other side of that is then we really need those resources to shift to the community. And looking to everyone in the community, I think you can probably agree, I don't think we've seen enough of that shift. So people are leaving sooner, but there's not the supports, sufficient support in the community to really help people with that journey.
Maggie?
I definitely agree with what you just said, Heather and Martha. It definitely is a huge issue, and it's one of the things that most of our referrals are looking for is housing, and unfortunately there is a huge lack of accessible and subsidized housing out there for individuals that are being discharged, and transitional living or short-term living is sometimes the option that we have to look at, and thinking outside of the box and looking for solutions that might work for a short term until perhaps something more ideal comes into play.
Blair and Helena, how long were each of you at Lyndhurst?
I was there for 8 months as an inpatient, and then approximately 10 months outpatient, which was like 3-4 days a week, sometimes 5.
And I was an inpatient for 4 months, and I didn't really participate as an outpatient physio and that sort of thing.
One of the questions that raises, we talk about discharge into the community and the length of stay. I think everyone's pointed out that the length of stay is getting shorter, and that creates challenges. And I think a question that sort of arises out of that is when a person is being discharged perhaps earlier than they're ready to, that leads to questions of, is the environment that they're going to be going to, whether it's home or somewhere else, is that environment ready for them? You know, do they have housing? Do they have the various things that they need? So I'd like each of you to comment on that, the sort of the challenges that poses when people are being discharged earlier and earlier, and how do you cope with those type of challenges?
I think when you're working with people who do have access to accident benefits money, I think that what they have an expectation that they're going to be able to have everything in place when they leave the hospital because the money is available. But because housing is such a complicated issue, and doing modifications even to a home that already exists takes a lot of effort, a lot of thought, and I think people are often feeling they have to do it really quickly, and they're already feeling very emotional. And it, you know, imagine for any of us doing renovations in our home and trying to carry on with our lives is a very stressful thing. you can't even imagine what it would be like when somebody's dealing with all of the issues that they're dealing with and now having to make decisions about modifying their house. So what I try to do is try to manage expectations for my clients, that despite the fact that money is available, it's really important to use that money as effectively as possible and to make decisions in a more informed way, so that it's usually best to plan on some kind of a temporary situation. And even those temporary situations can be expensive, but at least they do get the client out of the hospital and provide them with some opportunity to get a bit of a clear head and make a little bit more informed decisions about their housing.
Heather, I know that equipment issues are near and dear to your heart. Maybe you can help us with your perspective on that.
Sure, and I'm wondering if I have a few slides to share. I'm a keener today and actually have something. So this is some of the work that we've actually just recently been doing at Toronto Rehab to really start to understand. So what we've tried to do is be more objective around setting length of stay targets. So I looked to the clients in the room who've had their rehab at Lyndhurst, and I think one of the things people said was that it really depended on what unit you were on or who your team was. So people of very similar diagnoses and functional levels might have very different lengths of stay depending who they're working with. So we were starting to try to be more objective about setting length of stay targets. But then at the same time, it was important for us to start understanding when that length of stay didn't work, when someone needed more time and we extended their length of stay, what were some of the reasons? So I'll put that to the next slide. So what we found is that of the time we set a target, you can see over 43% of the time we extended that. So I think speaking to both Blair and Helena's stories, that certainly we try to tailor that to individual people's needs. But what was really important, and so if you look at this slide, so we started systematically looking at, okay, what were the reasons we had to extend length of stay? And the number one reason, so you see 63 times, the reason was that people continued to need intensive inpatient rehab services. So they continued to need daily therapy, they needed daily nursing care, and they needed that ongoing medical intervention. But what's interesting is of the discharge barrier, so the reason someone couldn't be discharged into the community, the number one reason was actually equipment availability and delays in equipment, which was surprising to us because I think all of us thought the biggest barrier has been housing, which you can see is also quite high. So that's the orange bar, the 36 times. But I just wanted to touch, so we looked more closely at the equipment availability piece. So if you look at the left-hand side, my right's my left, it's your, anyways. The blue, the green, and the yellow. So those are the reasons where the equipment was not yet prescribed. So we're talking primarily about wheelchairs. So 16 times the equipment, there was a delay in equipment being prescribed because the individuals were still changing. So as we've shortened length of stay, people are still changing and we can't make those determinations around what their needs will be for the next 6 months or years. So when we think of ADP policies, someone needs to be functionally and medically stable to complete an ADP prescription. And in these cases, we weren't ready to do that. So that was the reason why we were extending length of stay. Or that someone didn't have a discharge address. So again, we couldn't complete the ADP application because we didn't know where people were going yet. So what we're starting to see is that we've shortened the length of stay, but the other part of that system, the other part of the same Ministry of Health that looks at ADP, hasn't changed their policies, which so really has created some system issues that I think were important for us to really start to understand and have some information. The other side of it, when you look at that orange and the white, those are times when the equipment was prescribed, but then it was delays in receiving it. So either having the funding, so those individuals particularly who don't have secondary funding, and then delays with vendors or suppliers. So it's really provided us with a little bit more information that I'm looking to my colleagues at CPA. I think particularly it gives us a good, strong piece of data for advocacy around some system changes.
Heather touched on something that I think we get quite a few referrals on, and that's funding. Funding for equipment there's a huge gap for that, and right now it's even more scarce than ever. So we work very closely with the rehab team, the client, the family, our funding sources and try and help out there, as well as negotiating with the vendors how we can make it work to make everybody happy and make sure that clients go home with the equipment they need.
Helena and Blair, I'm interested in hearing from you. What would you say were the two most important factors to each of you in terms of your transition from rehab to home?
For me, the biggest factor was emotional, obviously. I'm starting a whole new life. I had a house on a lake. I no longer have that. Where am I going to live? Where am I going to go? Who's going to help me? The second one would be just that, finding a place. I need 24-hour care. I need to have that option in the building. I can't just go to an apartment. I need help from other people in order to survive. That's just my reality. Yeah, I guess that's it, really.
For myself, a huge part was the emotional part, making sure that I had, which I was fortunate to have, but having the people, a team around me that was wonderful, that could support me with my mood and all sorts of other things that went along with, you know, not knowing what your life was going to be about. That was extremely important. And the second thing, the barrier was finding an accessible place to live. That was huge, and I have dogs, and so I wasn't going to go anywhere without my dog. So I ended up having to go to a hotel, which was my choice. So I spent 13 months at a hotel because that was the only place that was accessible that I could have my dog. So it was expensive, but it was well worth it because I got to be with my dog. But the housing is a huge, huge issue. Huge.
It's interesting that both Blair and Helena, you both talked about the emotional issue, and I wanted to ask the healthcare professionals on the panel, how, from your perspective, how does that impact on the transition from rehab to home? Go ahead. Yeah.
I think the emotional piece is such an individual piece, and I think that as a private case manager, you have to really look at each person as a different person, as well as the family and the family dynamics, and really read where everybody's at, because there really is not kind of a recipe or prescription on how to deal with people. Some people are sort of take charge, no nonsense kind of people. They want to do everything on their own. Other people need to have their hands held very tightly, and they want you involved. So I think that, you know, that really reading people and figuring out what they need at every step of the way is an important thing to do. What I have noticed, though, is that it actually takes people many, many, many years until they can really deal with the emotional piece. So it's kind of always the underlying thing in the background, and you have to just wait until people get to where they need to go and offer them support when they're ready to take it.
And I think from my perspective, the whole emotional piece, there's such a gap in rehab. I mean, I think of how we're staffed, and we have 2 psychologists for the entire facility. And I think that's hearing from both of you, that was such an important piece of it, that so many of the professionals who are interacting with people while they're at rehab have never received formal training on emotional support and adjustment. I think of myself as a physiotherapist. Some of the conversations I had with the people that I was working with, and I was learning on the spot as I had those conversations. But I think that's where we're so fortunate that we have CPA in the building and really promoting the peer involvement. And I don't think anyone can learn better than they can from someone who has that lived experience. But not every rehab facility has that access, or someone might not be ready at that time. But that's where I think if we make the connections so that someone knows who they can go to. And I think that's what I've really learned recently, is that we have to change the focus of everything happening in rehab and everybody learning everything in rehab, but really changing the philosophy to set people up to have the problem solving, the self-management approaches that when they get out in the community, both they know who they can contact or they've made those connections. So I think that's the biggest part for me, that I think we have a long way to go in terms of really formalizing that emotional support.
Maggie?
Can I just jump in for 2 seconds?
Sure.
I'll forget if I don't. Touching base with CPA, the peer support program was so detrimental to me. To be able to just pick up the phone and either phone my match to ask a question or shoot a quick email to the coordinator and say, look, you know, I'm having issues with this, I don't know how to deal with that, was literally life-changing and life-saving. It was by far an amazing program, remains to be an amazing program, and I'm glad it's there.
Well, I couldn't have said it better myself. I was going to say that oftentimes, aside from the support that, you know, I as an RSC give the family and the client, I lean on my peers or my colleagues in the peer support program to really make sure that that emotional aspect is, I wouldn't say taken care of, but at least it's being acknowledged, and whatever questions arise or whatever emotions or feelings want to be discussed, we're there for them to support them throughout that transition and then after in the community.
Heather, I think you touched in one of your answers on a point that I wanted to just follow up on. How do you deal with a person, you said that, you know, we're talking about people coming out of the acute care hospitals quicker, people are getting discharged from rehab hospitals quicker, yet the moment they come to rehab, you want to get the rehab going. And people aren't always ready to start their rehab. How do you deal with someone who's not emotionally equipped to deal with their rehab when they come to your facility?
That's a very good question. I think we really struggle with that, and I think that's where sometimes we just have to take the time, and sometimes it might be one person on the team has that relationship with the patient, or it might be a peer. Someone opens that window that they start feeling ready to talk, to start engaging. But I honestly, I've talked to people who went through rehab and came back and said, now I'm ready to go through rehab. So they actually weren't ready, and it wasn't until they were out in the community that they realized what they actually is important to work on. So I actually don't have a great answer, and I don't know if the rest of the panel does, but I think that's one of the biggest struggles we face, especially as the length of stay has gotten shorter.
Martha, from a private perspective, do you have anything that you wanted to add on that point?
Well, I think given the fact that we have access to money and our job is to put in place a program that's going to meet people's needs, we are able to have those services in place when the person's ready. So when you're working with the person at Lyndhurst, you're seeing what the team is able to do there, you're seeing what can happen there, you're working very closely together, and I find that it's really important not to step on toes when somebody's in the hospital and not to overlap your responsibilities and really respect what's going on there. But then you know where to pick up the pieces, and when the finances are available, you can put in place the social worker, the physio, the OT. So from my perspective, we're very fortunate that if equipment hasn't been prescribed, well, we can put private physio in place and we can do the things that are required, and it makes a huge, huge difference.
Throughout today, we've been talking about a lot of the physical barriers, the physical complications that arise in cases of spinal cord injury. And in one of the talks earlier today, we talked about trying to give family doctors some more tools so that they can appreciate these type of complications. And the question I have is, in your view, what's the best way to manage ongoing medical complications, given the fact that a lot of family doctors do not have a very good understanding of spinal cord injury and the complications that arise from those injuries?
I'm going to let Heather.
Okay.
Again, I know this is a CPA conference, and I'm not I wasn't paid to promote CPA, but I am going to acknowledge the work that's been done around the primary care toolkit. So I think it's equipping family physicians with some of the tools and resources so that someone going back into their community with a spinal cord injury has something to provide their family physician with, so that there's some resources available. I know there's also been work around providing training for family physicians around autonomic dysreflexia. But I think there's huge issues from an accessibility perspective too. So many family physicians' offices are not even accessible, and there's not enough family physicians. But that's, again, I think back to some of the resources in the spinal cord connections, SCIU, so really making sure people, when they leave rehab, they know the resources that they can go to educate their family physician, any healthcare providers that they're working with, regardless of whether they're in Toronto or Timmins or wherever they are, so that there's some of those resources available.
And maybe Blair and Helena, you can sort of share your experiences in terms of with your own family doctors. How were they in terms of being able to deal with your injury and complications that may have arisen from time to time?
I'm extremely lucky, actually. I have a physician at the Ann Johnson Center, and they specialize in treating people with disabilities, so I lucked out. But there's many times where, you know, I can't make it to my family physician. I have to go to an emergency ward, and you just really have to advocate for yourself. But it's through things like peer connections with CPA, patient education, etc., that you have to learn absolutely everything about your body. You know, previous to my injury, I was one of those type of guys that even if my hand was cut off, I was like, oh, I'll go to the hospital later. It'll be all right. And I've realized now, you know, my life's changed, so I have to change. Obviously, I have to know everything about my body. I have to, if there's one little thing wrong, okay, why is that wrong? If I come to the conclusion that, okay, I have to go to the hospital, I have to go to the hospital. Sometimes, and like I'm not trying to be rude, but sometimes you're there and you know more than the doctor does. Because you've in some way had to become a doctor. And it's just being a strong advocate for yourself and knowing your body.
Yeah, I definitely agree with that. In my situation, I actually just got a family doctor 2 weeks ago at the Ann Johnson Clinic, so I'm really happy about that because now I'm being taken care of. I didn't have a family doctor for almost a year. I had a family doctor obviously before that. However, it wasn't, most of my medical care was done through the outpatient clinic at Lyndhurst, you know, by the specialist who does, you know, your urology, and then the physiatrist, and then the bone density doctor, and then on and on and on. But my family doctor, I wasn't able to get into the building, which was a problem. And then she moved, and I wasn't able I'm not able to be examined in her office because I can't transfer onto the table because it's too high. So I never really went to see her anymore. I kind of just used the physiatrist and the services at the Robson Clinic down at Lyndhurst for whatever my issues were. So.
Maggie, did you want to add?
I think the panel's already said a lot of what I was going to say in terms of, you know, CPA priding themselves and striving to really help individuals with spinal cord injuries to educate themselves and to understand the complications of an SCI, whether it be on a one-on-one basis with a peer with an RSC, or whether it be through peer connections or knowledge mobilization seminars, or through the Spinal Cord Connections Center. Basically, it's arming yourself with all the knowledge and information that you need to move forward and help your health practitioner do his or her job better.
I think someone raised, and I think it was a good point, that, you know, medical practitioners are different in different parts of Ontario. I mean, we live in an area that has fabulous facilities and doctors that might be a little bit more up on some of these type of injuries than in some of the remote sections of Ontario. So it's important to remember that when people live in remote sections of Ontario, they may not have the same type of access to medical treatment, or certainly not access to the type of facilities like Lyndhurst and Toronto Rehab that we have here in the metropolitan area. The question was if the panel could comment on other programs outside of Ontario that people might have access to, such as Second Look in Chicago, or some of the other types of programs that are outside of Ontario.
I think there's a number of programs in the U.S. like Second Look. A number of the rehab centers have programs where they continue to bring people back for longitudinal follow-up and services as they're needed. And certainly that Second Look approach is sometime after they've underwent the rehab to come back for additional assessment and treatment as needed. I think the one thing we need to recognize, though, is that it's a different funding system and people are paying for that. What I think we need to be advocating for in Ontario is that every rehab center, or every part of Ontario has the systematic longitudinal follow-up so that people can come back to their own center and that they don't have to go to the US. I think we have all of those services in Ontario. I just don't think people have consistent access to them. I think Second Look is a great program, but I think it's unfortunate that people have to go to outside of Ontario to pay for that.
Certainly when you're dealing with cases that involve people who've been in a car accident or any other type of injury where there's insurance funding in the background, you have to think about the cost of these programs versus the benefit of going to the program. And my experience certainly has been that these programs outside of Ontario are very, very expensive. And they chew up the people's resources very quickly. And my concern as a lawyer representing people is I want to try to help people make good decisions about the way that they use the resources that they have. And sometimes when it's early on in a person's injury, they're not equipped to be making those type of decisions. And they definitely want to get better. That's the first thing in their mind. And they're grasping for anything that will make them better. And they don't really think about the cost. But they will think about the cost when they've spent $250,000 or $300,000 of $1 million of available medical rehab benefits after it's gone. And then all of a sudden they're running short of money for continued services when they come home. So I'm not advocating for or against those type of services, but I think people, when they suffer any type of catastrophic injury, have to be very sensitive to the costs of rehab. And that also goes, that same point applies to even private rehab when people come out of rehab facilities. There is limited amount of money. And part of our job as lawyers for acting for people is to help people manage their money and manage it in a way that's effective and cost effective. So it's a problem. I acknowledge that's a problem, but I think it's a reality of most situations that money is limited. And it's a reality we have to face into, and even more so in the situation where people don't have private funding. Your family support structure, your friends, the support structure around you, how important is that to anyone who has suffered a catastrophic injury? Yeah. Why don't we start with Helena and... Yeah.
Okay, well, I'm very fortunate to have a very supportive family. And that's just huge, and it's huge today. I don't think I could have gone through it without them. Can I also speak about the other types of support that I had?
Sure, absolutely.
Okay, so I was fortunate, and I had Craig Brown working with me as my lawyer and Carmen Spinal, and I got Martha Binstock, and now I have Maggie. But when you go through the injury and oh my God, your life is completely changed and everything's a disaster, and you kind of don't really want to be doing anything yourself. I was one of the people that needed my hand held very tightly by Martha. I don't even know what the question was. I kind of forgot.
The importance of family and friend support.
Oh yeah. So yeah. Anyway, it's actually extremely important because I had support from a great team. I also had a social worker that helped me. I didn't see the change from being one way to the way I am today. I can feel completely. I don't think I would be as such a positive person or been involved in sports. That's really helped me a lot. Getting involved in things, having my parents and my team encouraging me. Craig was sailing, so why don't you try sailing? You know, Martha's, why don't you try skiing? You used to ski, why don't you do this? Why don't you do all those things? And if it wasn't for encouragement, I wouldn't have been able to do it all on my own. That was just me. And so I had a lot of support weekly. I could call Martha anytime. I could call another woman, Lee Craney, all the time. I could call the social worker. I had an OT. I had all these people helping me, and I really couldn't have come out of it as well as I did without all of that support, because I had other issues at the time as well, and I needed to have emotional support. So it was friends and family, having all them around you is critical. If I answered the question.
Yes, you did. It raised something. Martha said something you've said has raised something she wants to mention. So
I just want to say, if anybody who, as a case manager, has had a file where the PGT is involved because the family members are not available, I think it's sort of goes without saying that we see the value of having family members there, because in terms of our role, it multiplies a gazillion fold. So having family and friends involved is exceptionally important. And there are some people where mothers and family members are very, very involved, and I think that increase the recovery rates and the successes of people a gazillion fold. There's a huge, huge difference when family members are involved, and they do need the support very badly.
And as an RSC, I can tell you that many times we are dealing with the family members even more so than the individual with the SCI, and supporting them because they've gone through something huge and traumatic, and because they are supporting the individual so much, and they want to stay strong and show that they're strong and supportive, that a lot of times it's, you know, us that they turn to, or other providers that they turn to for that support, so when they are crumbling, we can help pick them back up.
I know personally, as a peer support volunteer, when I say first go into an ICU to meet a newly injured spinal cord patient, I will say 90% of the time, they don't really want to see me, they don't want to talk to me, they don't want to hear what I have to say, they're not going to be like me, they're, you know, in their mind, they're still walking. So for the first little while, it's actually support with the family. Oh, when I was at this stage, this was happening, this was happening. Well, what does the doctor mean when they say that there may be spasms? What does why is he doing this? Why is that? And I say, well, when I was in his position, this happened, that happened. And it's more support at first with the family. And then later, the person comes around, right, as acceptance sets in. And I think that the family, you know, knows at that point that CPA is behind them 150%.
in 30 seconds or less, I'd like to ask each of you if you have a takeaway message to the audience today. Martha?
My takeaway message is that regardless of the fact that somebody may have access to both TOR and AB funds, it's really important to connect them to CPA. And our case with Maggie and Helena, Helena only had AB funds, and as we all know, that's not enough for somebody over their lifetime. So the partnership that we developed with CPA right from the very beginning, so that when we needed to transfer over, when the case was settled, that things would be in place. I can't promote them enough, because I think that it's really important, and often people think because they have money that they don't need to connect with CPA, and that's not true.
Heather?
So I think my take home would be, certainly from the very beginning, is really, as much as possible, every healthcare provider and everybody working with someone with a new spinal cord injury is really trying to equip them with the individual knowledge, the resources, the ability to advocate for themselves, to really start asking those questions and knowing where to go for information, recognizing that not everyone can learn everything at the time they're in rehab, but really knowing where to go and know how to problem solve through some of those challenges along the way, but really changing that philosophy and really making it about a self-management and really self-directed approach to being the consumers of their own body.
Thank you. Blair?
Sorry, that did not sound right. Not consumers of their own body, but being consumers and really being the experts in their own body.
Blair?
I'm going to sound like a broken record, but supporting the CPA in all of its endeavors and every program that it has to offer is the most important thing that, in my opinion, can help a spinal cord injury survivor and their families.
Maggie?
I'd like to say that open communication with the individual, with their family, with the team, whether they're in rehab or whether they're at home and they're using community agencies, so that collaboration can flow through and thinking outside of the box for solutions.
Helena?
Just for everybody's different journey and all that kind of stuff, everybody needs support, and I definitely believe that the family also needs a great deal of support as well, dealing with this injury or circumstance that happens in life. So support's very, very key.
Well, on behalf of myself and everyone here today, I'd like to thank every member of our panel for their sharing their experience and their expertise with us. I'd like to thank all of you for your participation. Thanks very much.